everyone and welcome to Grad Chat. I'm here live at UKIO 25. My name's Jo McNamara. I'm joined by fellow host Joel Canderson.
Hi everyone.
So in the pod box here today we've managed to capture someone else. I think I'm making it sound like I go out and just drag everyone in.
I went this time,
yeah. So. Would you like to introduce yourself, please?
Yes, I'm Megan Wakelin. I work for Boston Scientific, specifically in the Space Law division.
How did you get into that?
So my background's nursing. I worked on the wards for 4.5 years, and after COVID decided to venture into new pastures, but still hopefully helping patients. I ended up in neuromodulation for a couple of years before joining Boston 9 months ago.
What is neuromodulation?
So it is a method of stimulating certain nerves. So you have two leads put into your back under general anaesthetic usually, and it works on kind of the dorsal horn, and it's for neuropathic pain. So that was really interesting.
Yeah.
But here I am now.
Entering the world of radiotherapy and
I know, and what a world it is.
Indeed. What's been the biggest kind of, not necessarily challenge, but what surprised you the most by entering into this space?
I honestly did not have any appreciation or idea of how much goes on, like in the basement of a hospital where there's no windows, like how many people you find down there and how many kind of innovative technologies there are. Like even just learning about radiotherapy was not something I did as a nurse. I did palliative care. That was as close as I got, like palliative radiotherapy. So just seeing how many people are involved in, let alone the logistics side of it, but in that patient pathway, I just think it's fascinating and a lot to get your head around.
I was going to ask something I forgot.
I'll ask.
Sorry.
In terms of kind of your clinical training, you said you kind of touched on that you learned a little bit about oncology. Do you feel that there should be more oncology teaching as a kind of registered nurse?
I think so, definitely. I mean, I don't remember learning an awful lot about oncology in my nurse training. I think I was mostly exposed to it when I worked in acute medicine, because we had an acute oncology nurse that quite often the patients came to our ward. We had like seven specialties and acute oncology was one. So I learned a lot from them, and we also used to get the metastatic cords before they got transferred to our regional centre. So a lot of it was learning on the job. Like it would have been nice to have more in the curriculum, to be honest.
Yeah, because I know I do work with the Ascend project, which is brilliant in terms of kind of providing that post-registration education. But with the statistics of cancer, I always think it's quite surprising that there's not more, and it's not just nursing, it's physiotherapy, occupation, that there's just not more education around cancer.
Yeah, I guess a lot of your nurse training as well, it does depend on where you get your placements.
Yeah.
So like my management placement was in theatres, and I was like, oh, I'm never going to be a theatre nurse. Like, why am I not on a ward learning everything I need to know, like about drugs rounds?
Yeah.
So I do think a lot of it as well depends on what you're allocated. Obviously, they do try to give you a broad experience, and obviously you can't go too into it, because then you'd be doing another degree, wouldn't you? It's that fine balance. But yeah, I think I just.
But you're enjoying it now. You're involved in it.
Now I understand what all your terminology means a little bit more.
Oh, aren't we a nightmare with terminology and acronyms?
Lots, yeah. There's a lot, and I think, I don't know, everyone speaks really quickly with these acronyms, and at the beginning I was like, what? I don't know what any of that conversation meant. But no, I'm getting the hang of it.
What are you hoping for from this role within the next few years?
So when I was at uni, my first module was kind of on health inequalities, which I just found really interesting. And in this role, my goal would be is that even if everyone doesn't believe that patients need spaces, I think making sure that patients have equal access to that, if that's something they want or if that's something their team recommends. At the moment, it is a huge postcode lottery, and I don't think that's when the NHS set about in 1948, whenever it was. They always said like equal access for all, and regarding spaces, and I'm sure in other areas of cancer care, there just isn't that equality. So my goal would be to make sure that patients have a lot more equal access to this therapy if they wanted it.
If people are listening and they're thinking, I've never heard of a spacer, how would you describe what it is, what it does?
So I've described it as It's difficult for professionals or for patients. So it's a perirectal spacer, so it's a gel essentially that is injected through the perineum, and the goal of it is to move your rectal wall out of the way so that when you're getting radiotherapy, there's a much less chance that those beams are going to hit your rectum. Obviously, if those beams hit your rectum, then you are at a higher risk of developing complications, bleeding, etc. So that's how I'd describe it in a nutshell.
But they're not used by everyone.
No, and I think a lot of that, there's loads of reasons for it. I think obviously money, there's always a part to play, isn't there? But we do have workarounds for that. Awareness, I think there's still physicians that have never seen it in their training or in their practice, even if they have been a consultant for a long time. So I think that side of it. And then actually being able to deliver it as a service when hospitals have no room, no space, everyone's overworked, and then it's people do want it but they can't find the right person to do it. So it's unpicking it in every site, what's the issues, I guess, or the barriers. Or at least or just at least having like specialised centres in every, I don't know, cancer alliance, so that they could send if possible.
Because linking to cancer alliances then, from a commissioning perspective, have you been able to get involved in that side to understand why maybe there's hesitation as well from that angle?
So obviously when it first came out, it was part of the ITP programme, and I guess it was before I joined the role, but the NICE guidance changes will have freaked out a lot of people. Because obviously initially it went to special measures, then it went off special measures, but sometimes when you speak to people they're like, no, it's not NICE approved, we can't use it. And it's not that it's not NICE approved. As a site you just need to be collecting data on your patients, which in cancer everyone's collecting data on everything. In radiotherapy you're collecting data on everything. It's not like it's a huge thing, but I think when that guidance came out, obviously the first reaction is stop, hold our horses, like what are we doing, when, especially because it was only a couple of, like, not loads of sites. And I think me coming into this role fairly recently, I'm still trying to kind of make sure that message is across that no, you can still use it safely. Loads of hospitals do. So that's a communication piece, getting in front of the right people.
Brilliant. And what would you say for anyone who's maybe in a clinical role and thinking about transitioning to industry?
I think it's not for everyone, and I think my first 6 months I kept thinking, what have I done? It is really different, but I think coming from a clinical role, you can bring so much to these roles. You've got that authenticity. You're not there just selling a product, you actually really have a good understanding about that patient pathway, and you care about kind of whatever you're selling could benefit them. I think as well, coming from clinical, you find it easy to build relationships with consultants because you're used to having that interaction with them. You're not scared of them necessarily, or you can have like a bit of crack with them and have a conversation. I do think it is really worthwhile, and I do think for me, as nursing, I was helping kind of one patient at a time, whereas in this I hope that I can help much more patients, even if they don't know that I'm helping them necessarily. So I think it's not for everyone, but I love it.
Well, thank you so much for joining us.
Thank you for having me.